Alrighty. Good morning, everyone. We're going to go ahead and get started with our first presentation of the day. We have with us Gavin Taylor, who's a professor of computer science at the U.S. Naval Academy. He earned his PhD in computer science from Duke University and has since been published more than 30 papers about artificial intelligence and machine learning, with a recent focus on behaviors and vulnerabilities of neural networks and applying reinforcement learning to enable smart sensing on battery-constrained devices. As an educator, he has won several teaching awards and is chairing the development of the Naval Academy's new major in data science. He lives in Annapolis, Maryland with his wife and young daughter and serves on the CRISP Consumer Advisory Council. Additionally, we also have Dr. Mark Rabner with us. Dr. Mark Rabner is an MD, MPH pediatrician and preventative medicine physician who serves as the chief medical officer at CRISP. Dr. Rabner sees patients as a pediatric hospitalist at the Children's National Hospital in DC. He's passionate about using technology and data sharing as a tool to improve patient outcomes and address complex healthcare challenges at scale across clinical, community, and public health sectors. With that, I will turn it over to Gavin Taylor, who will walk us through what AI actually is.
Yeah, thanks so much, Kevin. Can you see my screen okay? Is that working correctly?
Yes.
Perfect. Thanks a lot. Yeah, good morning. Thank you very much for that introduction. Just a brief moment about the sort of division of labor here. So I do artificial intelligence and machine learning as a field. I am not in healthcare myself. And so my role here today is to introduce artificial intelligence to you. I'm going to assume that you have no background in it at all. I apologize if that's not true. And so once I've done that, we're going to need Dr. Rabner to take us home and actually talk about how we can apply those concepts to healthcare itself. I do have to start with the legal disclaimer that while I work for the Navy, I do not speak for the Navy. All my positions and opinions are my own. I'm not a spokesman. But that does provide a convenient segue into perhaps thinking about why is it appropriate that the Navy is here to talk about these things. And there's two answers to that. One of those answers is I'm less Navy than I appear. I'm just a college professor whose students happen to wear uniforms. But the other is that healthcare and the military share similar challenges when it comes to applying new technology. Namely that there are strong decision makers involved, human decision makers involved who are used to making decisions. There's a lot of information coming in at once, and the decisions that are made have to be right. And so there's a lot of correlations, and I've actually seen a lot of cases where the military and healthcare community work together. But this also brings up perhaps a larger question. As Megan mentioned in her introduction, nobody's allowed to have a conference anymore without talking about artificial intelligence. And so the first question might be, why is that? Why are we hearing about artificial intelligence everywhere? And of course, the answer is the hype. This is my favorite article that we might use for an illustration of the hype. You'll notice that this is promising to build a system that can walk, talk, see, write, be aware of its own existence, reproduce, and will be able to do this in a year and at a cost of $100,000. And the reason this is my favorite hype article is actually this article is from 1958. So we have been here before. This is actually the third AI boom. We had a boom in the 50s where we were convinced that this technology was going to solve every problem that we had. And then we backed off of that idea. And then we had a boom in the 80s where we were convinced that artificial intelligence was going to solve all of our problems. And then we backed off of that idea. And here we are again. Now, the reasons that it keeps on coming up is because this technology really does have actual promise in helping people, an actual potential to help people, and actually already is helping people. But as always is the case in a hype cycle, one of my messages here today is going to be encourage you to be aware of the ways in which you can expect AI will help, but also be critical when you hear other people's promises. So here are the elements that I'm planning on talking about today. First off, I want to introduce to you just the basic idea of what is artificial intelligence really? What does it mean when we say that a computer learns? What do those terms actually refer to? Second, I'm planning on talking about how it is that we can work artificial intelligence into decision-making in a difficult and dynamic and changing environment, such as healthcare. And third, if somebody is going to use artificially intelligent tools, there are some opportunities and dangers that they should be aware of. And so as potential users yourselves, I thought that would be an interesting thing to mention as well. So I want to start by describing a problem that up until about 12 years ago was something that people found very, very easy to do, but computers found extremely difficult to do. And that's just the basic question of, is this picture that I put up in front of you here a dog or a cat? Now, of course, we all know this is a dog. I have a 2-year-old daughter. She knows that this is a dog. But I want you to take a moment and I want you to think about how it is you would explain to somebody how you can tell if a picture is of a dog or of a cat. Were this my class, I would actually ask you to write things down. So perhaps a dog has 4 legs, perhaps a dog has a tail, perhaps a dog likes human company. Whatever it is that you choose to write down, I'm confident we can come up with some illustrations of dogs where those things that you wrote do not appear in those pictures. But nonetheless, we're very, very aware of the fact, with no difficulty, that these are pictures of dogs. So when we had the problem of trying to make it so that computers could understand images, we had this situation where there were so many exceptions to any set of rules that we could write, that writing an explanation to the machine about this is how you can tell if this picture is a dog or of a cat was prohibitively difficult. So even though we as humans found this very simple, writing a computer program that could do that incredibly simple task proved to be too difficult, even over generations of very smart people working to solve that very kind of problem. Now, as I mentioned, this was hard up until about 12 years ago. And this was when this next boom began, when we reached the next level of our capabilities in artificial intelligence. And so I want to describe this to you as a learning problem and how we can use artificial intelligence to avoid this difficulty of having to explain what we mean by a dog or a cat. So we start by building a data set. So we say, we know that these following things on the top are dogs. We know these things on the bottom are cats. I'm going to make a folder full of dog images, and I'm going to make a folder full of cat images. And the bigger those folders are, the better off this is going to go. So these data sets can reach into the realm of the millions of examples. And we're just going to label that pictures of dogs, we are going to label with a 1. Pictures of cats, we are going to label with a 0. By the way, just for fun, you see my disclaimer there about Google Gemini. Many of these pictures are not actual pictures of dogs. These were generated by artificial intelligence systems. I encourage you to try to figure out which are which. So, okay, we have our data set of dogs and of cats. And what we want to do is we want to build a computational system where we take this picture, we feed this picture into some mathematics. So first off, we have to take this picture and represent it as numbers. Every picture is made up of pixels. Each of those pixels has a red, green, and blue value, which is a number. So therefore, a picture is a whole lot of numbers. So we can take those numbers and we want to build a system where we feed those numbers in, some math occurs to those numbers, and what pops out the back is a 1 or a 0, which accurately describes if this is a dog or this is a cat. And so the way we do this is by using our data set. So we take our data set, we take a bunch of pictures of dogs, we take a bunch of pictures of cats, and we start off with actually some random mathematics So we don't know exactly how it is to build such a function that outputs a 1 or a 0. But what we can say is, here's some math. How well do we do? And the answer is not well at all, because it wasn't very well thought out mathematics. It was just some math. It was some math that takes in pixel values, does some multiplications, does some additions. What comes out is the 1 or a 0. And of course, that's wrong because we haven't thought about it very hard. But what we can do is we can say, well, how is it that I can improve this math just a little bit so I'm more accurate than I was on this data set? And this is the process of learning. We take these examples, we push them through our proposed mathematics. We say, wow, that didn't work very well at all. But if I adjust this math just a little bit in this direction, in that direction, in that direction, my accuracy is going to go up a little bit. The process of a machine learning is repeatedly performing that process. Here's some images for which we know what the right answer is. Spit out the predictions of what the math believes those answers are, and then adjust the math to be a little bit more accurate. And if we do that long enough and over enough examples, then when we're done, we can say, well, now I have a new image. And because this mathematics works on these millions of data points that I've trained it on, I have some confidence it's also going to work on this new example. So when we talk about training, when we talk about artificial intelligence, you'll notice that there's nothing in this process that is logical. There's nothing where it says, oh, I've learned that floppy ears means that it's a dog. That's not happening. It's a purely mathematically iterative process to improve some mathematics until the numbers that are coming out the back end of this box are right. There's not a lot to understand about why it's making the decisions that it's making. We just know that over millions and millions of examples, it tends to be right. So we can take this example of dogs and cats and perhaps suggest some more interesting examples. So for example, perhaps our data set consists of images of brain scans, and some of them have tumors and some of them do not have tumors. And we can build a system that learns to predict whether an image contains an image of a tumor or not. Alternatively, perhaps given a person's location data from their cellular phone, perhaps we can predict how that person is likely to vote, what issues determine how they vote. This type of information is used to advertise anything to you all the time. Third, perhaps we have a whole bunch of recordings of somebody speaking, and we have transcripts of what it is that was said. And again, we can perform this mathematics so that we can feed in a recording of a voice, and what spits out is an accurate prediction of what it is that that person said. Or perhaps we have a data set consisting of large blocks of text that we've downloaded from the internet. And we want to train a system to say, here is an incomplete block of text. What is the next word that is most likely to appear in this block of text? That's the underlying technology behind your chat GPTs and your generative AI models. And lastly, here is a number of documents. We would like to understand if somebody's made a Google query, which documents are most likely to apply to that Google query. So all of these are just different data sets, but the same concept as we applied to our cats and our dogs. In general, we have a large data set for which we know what the right answers are. We build a mathematical model that tends to perform well on the examples that we have. And then we use that model to predict examples that we didn't have while we were performing training. And I wanted to particularly highlight these last three examples. If we rewind to the question of why is it that every conference has a session on artificial intelligence right now, in large part, this is because in the last 2 or 3 years, our most recent jump in the technology has been in the ability to make systems that could communicate with people in their own language, to understand the text, to understand their speech, to create images in such a way that the person can understand them with their own eyes. We don't have to have a translation between the machine and the person anymore. I don't think in the last 2 or 3 years, our actual capability at making better and more accurate predictions has improved, but our ability to build systems that communicate with people, that interface, has improved dramatically. So now we have the question of how is it that artificial intelligence can be used when we're performing some complex decision-making, like in the healthcare community, or in really any other decision-making process. And so the first thing to note is, in general, we are not in a position technologically to take anybody's jobs yet. We're just not good enough at it yet. So there's certainly a lot of discussion about how will these systems impact the economy. Those are legitimate questions. In some fields, those things are happening now. But in general, people whose job it is to make difficult decisions, those jobs are not yet in danger just because we're not good enough at this yet. But that said, we can use artificial intelligence to help that person make better decisions. So for example, perhaps if somebody is making some type of decision all the time and most of the decisions are easy, but a few of those decisions are hard, perhaps we can build an AI system that handles the easy questions while allowing the hard ones to filter through onto the more capable human. Or perhaps the human is just not able to understand the number of input informational channels that a machine can. And so it can involve more information and provide a recommendation that can help the human make that decision. But at the end of the day, I want to reinforce the idea that it's still going to be a human making decisions. But when you integrate that artificial intelligence into that process, that can heavily impact the workplace dynamics. Just the idea that you have a new, highly capable system making recommendations to people can really impact how that organization works. And so I have a case study here that really illustrates this example well, I think. Down at the bottom are some citations in case you're interested in this. This is something called Sepsis Watch, which was a system that Duke University built in order to predict whether or not, given somebody's medical records, if they were at high risk of developing sepsis. In general, that system worked well. The way it worked was that if a patient was flagged at high risk, then this would appear on a dashboard to a nurse who would alert the attending doctor to that, to the fact that this patient had been alerted. Now, the human dynamics element came from that oftentimes the attending doctors had a very human and understandable response where they received a call from a person that they had not worked with about a patient that that person had not seen, involving a tool that could not explain itself, that arguably was saying that that doctor had missed something. And so there was a lot of tension there in this workflow. And so significant emotional labor on the part of these nurses had to be used in order to say, when is it that we talk to these doctors and how is it that we talk to these doctors so that this information is used as productively as possible to help patients. AI systems are incredibly powerful. They can do great things. Where they can do great things, I argue we should use them. It's also important to understand the ways in which artificial intelligence can do harm. So first off, AI can be wrong in convincing and authoritative ways. And so here's an illustration of this. I fed this prompt, explain why Gavin Taylor was fired from the US Naval Academy, into a model like ChatGPT. It uses the same technology that ChatGPT does. And so what it did was it started predicting one word after another word. So it said, well, I think the first most likely word in my answer is going to be the word Gavin. The next most likely word is going to be the name Taylor. After that, the most likely word is going to be Anne. There's nothing in this study of statistically what words are likely to come next that it all says, is what I'm saying correct? And so as I complete this sentence, I want you to remember that what it is saying is not correct. But this was literally my first try of feeding this prompt in. Gavin Taylor, an alumni of the US Naval Academy, was dismissed following allegations of sexual misconduct. This did not happen. This is not true. This has never happened. On March 10th, 1996, I was 12. But nonetheless, it comes across as very convincing and authoritative. And so people tend to believe these models even when they're not designed to be used in that manner and believed. Also, these models can be biased in important ways against individuals and groups. So here, for example, is our data set of dogs versus cats. You'll notice that accidentally, these cats all ended up having a disproportionate property of having these stripes. So if you're trained on this, perhaps the model has learned that animals with stripes are cats and animals without stripes tend to be dogs. And so when you feed in this new image, because most of the examples of black furred animals have been dogs, it will tend to get this type of example incorrect. Now, this is cute when we're talking about kitties and puppies, but we're able to come up with lots of examples where this is very dangerous. So for example, in facial recognition, where you need lots and lots of pictures of people from different angles in order to train, the only people that we have lots and lots of pictures of tend to be celebrities. And celebrities do not tend to have the same racial proportions and racial mix, racial proportions as the general community. And so as a result, we had a problem for a long time where facial recognition was far better at identifying light-skinned individuals rather than dark-skinned individuals, which of course is very dangerous when you use it in law enforcement. It may be that if you're building a voice recognition data set, you're not representing all accents, or you're not representing all speech disabilities, and you are eliminating people's ability to use this tool. Data sets which are based on human decisions will reflect human bias. So for example, it would be a very bad idea to build a system that automatically predicts whether somebody should be given a mortgage or not, because that data tends to be racially biased in terms of past decisions by humans. And lastly, medical data sets tend to represent the people who are able and willing to frequently receive treatment, and they're willing to share their data. And again, that data set is not necessarily representative of the people who most need the assistance of the tool. So my conclusions here are, first off, AI is absolutely developing quickly. Anything I say today about what the capabilities are and are not in 2 years are likely to be wrong. But even today, they can work extremely well on some problems. Second, AI can be used to help a person make better decisions. So if these tools start to come into your workplace, certainly you should be critical about it, but consider that these might be very powerful and very helpful and might improve people's lives and might improve decision-making. Third, integrating that AI is a very, very human process. The ability to make it so that artificial intelligence works capably with humans is a difficult problem. And lastly, it is easy to accidentally cause harm by having some biased data in ways that you were not expecting. So that's the end of my time. Now I'm going to turn this over to Dr. Rabner, who's going to take us home and actually apply this to healthcare.
Thank you, Professor Taylor. So now that you guys are all experts on artificial intelligence, I'm sure you're also wrestling with how to best implement this type of technology, given its benefits and risks that you just heard about. How do we implement solutions that are responsible and still have our patients in mind? And I have been reflecting on CRISP's history in Maryland and how we've successfully navigated these types of challenges and implementing new technologies before. This is CRISP's vision to advance health and wellness by deploying health information technology solutions adopted through cooperation and collaboration. And for 15 years plus, CRISP has been collaborating with different healthcare stakeholders throughout the state to improve the health system in Maryland. And we've used innovative technology to do that. CRISP was born when 4 Maryland organizations came together because it was almost impossible for outpatient care teams to get discharge summaries or know what happened or when their patient was admitted or discharged from the hospital, let alone see the actual X-ray that was performed during the hospitalization or look at the labs that were done. And we also had really limited visibility into the population level views of the data at the state level and weren't able to make the same data-informed decisions that we do today. And we can even take this for granted today because it's become so routine in our daily work. And it's important to say that it wasn't CRISP staff who came up with the ideas to make CRISP what it is today and to partner to make the Maryland healthcare system what it was today. It's people like yourselves that are at this summit. And it was partnerships and collaborations coming together to solve problems and really rolling up your sleeves to implement solutions that actually worked for patients and teams. And that's really how we still collaborate and innovate today. And together we created this IT infrastructure that allowed us to make Maryland what it is. And now we have this new tool at our disposal, or maybe not so new, given the article that Dr. Taylor shared from 1958. But we know it can address some very complex challenges. And AI certainly has unique risks, but we've been here before and we've confronted technology and policy challenges previously together and created a future that worked better for us and for our patients. And so we still have these challenges today in healthcare, and we now have this tool that can help us confront those challenges. And on the next slide, so the year before CRISP became the designated HIE for the state in 2008, the Institute for Healthcare Improvement came out with the triple aim, which is now the quintuple aim. And this was a framework to help healthcare stakeholders to create solutions to improve the healthcare system as a whole. And since then, CRISP solutions have really continued to address some of these aspects of the quintuple aim to address and make a more robust healthcare system for everyone. So I'm going to share a few AI use cases from around the world and how they hold some promise to making the healthcare system better in each of these elements of the quintuple aim. I'm not necessarily suggesting that we adopt these solutions in Maryland, but I hope these examples get your wheels turning on some of the variety of different solutions that are out there and how they can really solve big problems. So on the next slide is how has AI been used to improve patient outcomes. Many of you may be aware of the increase in multi-drug resistant bacteria and other organisms, and the fact that our new antibiotic pipeline is very small. So to solve this problem, or to think about this problem differently, MIT researchers about 5 years ago trained a model on all the existing antibiotics. They then asked that model to look at a library of 6,000 different chemical compounds and say which of these chemical compounds is most likely to have antibacterial activity. They then ran a second model on top of that to say which of those compounds has a low side effect profile in humans, or is likely to have a low side effect profile in humans. And they identified a molecule that had actually previously been identified and investigated as a diabetes drug. And when they used it to treat bacterial infections, it actually had broad antibacterial activity in mice when they initially studied it. They actually named it Halicin, HAL for 2001: A Space Odyssey. And Halicin is now being tested to prevent central line infections in humans. Another model on the top right of your screen used natural language processing of admission notes to predict severe maternal morbidity during delivery encounters. And so this used real-time risk stratification with already existing data to predict which patients that presented for delivery were more likely to have severe maternal morbidity, which includes things like needing to go to the ICU, having lots of blood loss, and the top decile score using this already existing notes had 6 times higher risk of maternal morbidity than those at the bottom score. Historically, diagnosis codes have been used to try to risk stratify patients with severe maternal morbidity, but those diagnosis codes end up being put into the system at the end of a visit, which is not super helpful when the patient presents and you do the history and physical. And so this helps with real-time data and the identification of these populations. Then the third article was published this past fall by the Mayo Clinic, which described an AI model that was trained on 7 million different ECGs or EKGs. And for those that are less familiar, EKGs are relatively cheap and relatively easy to administer. And they're historically used for identification of when someone is having a heart attack is one of the main uses of an EKG. But this model was helping predict if a patient would have a heart attack in the next 3 years. And the highest scored individuals had 12 times the risk of having a heart attack than those at the bottom scores. EKGs have never been used to predict heart attack like in this way before. And it's easily accessible and cheap to perform. So it's not just clinical outcomes that the quintuple aim tries to improve. On the next slide, there's also been applications of AI to enhance patient experience. On the left side is a study out of a group in England that used natural language processing and machine learning to read all of the comment cards that they received from patients and families. This group would get 2,000 comment cards a month, and it would take them weeks to months to just review the information and categorize them and know what to do with it. And they trained this AI model to identify themes and prioritize negative feedback so that they could escalate that negative feedback to the appropriate teams and get those issues resolved. And that happened in minutes. On the bottom, this other study used a GPT to improve the readability of patient materials in orthopedics. So they ingested Orthopedic Society websites into this AI model, and they asked it to improve readability for common orthopedic procedures. The websites were initially graded at a 10th to 11th grade reading level. Afterward, the AI improved the reading level to the 5th or 6th grade, which is what's recommended for patient-facing material. And evaluators that looked at the output also saw that there was still sufficient level of nuance for patient education, and there were no factual errors in this study. So now imagine you're a patient that never graduated high school, but is having a hip replacement. Now you get this material before your procedure and have a better understanding of your expectations of what should happen during the procedure and after. On the next slide is provider satisfaction. So many organizations are probably already implementing this solution or at least thinking about it. But for those that are not familiar, there's technology called ambient listening technology that listens to a conversation between the doctor and patient during the visit. It then synthesizes the conversation and writes the clinical note almost immediately after the visit. And clinicians don't need to spend time documenting on the EHR and looking at a screen during the visit. They can just talk to the patient face to face. And this is a study out of Kaiser Permanente Medical Group, where they piloted this program with 10,000 physicians and over 300,000 patient encounters. And then they compared the intervention to a control group. And the graph on the right, the dotted line, if you're above the dotted line, that means the ambient listening AI, medical scribe, is better at control compared to control. And they saw that what's called pajama time, or time working at home documenting, was better. And their clinicians that were using this technology were spending less time out of their typical workday documenting. They also surveyed patients, and 81% of patients said that their physician spent less time on a computer screen during the visit when they were using this technology. On the next slide, there's been a lot of questions about the impact on cost. And there are some estimates that AI will save the US healthcare system 5 to 10% over the next 5 years. And that's over $200 billion per year. I mean, we'll see what happens there. But this is a study out of Singapore that evaluated a deep learning system to detect diabetic retinopathy. Diabetic retinopathy is a consequence of poorly controlled diabetes, or can be, and can result in blindness if not identified, addressed, and the diabetes not well controlled. And these AI systems look at a picture of the retina and have been shown to be as effective as human reviewers of diabetic retinopathy. And in one model, the AI helped triage patients. So similar to what Dr. Taylor mentioned, the easy stuff, let's let the AI do. The hard stuff, let's let the humans do. The AI basically triaged out the patients that did not have diabetic retinopathy or had very mild disease and didn't need intervention. And then they sent the more complex patients to humans for confirmation and for further treatment. And they saw a 20% reduction in cost each year from this method without a change in the outcomes of these patients. And on the next slide is how AI can advance health equity. Now, I know we've heard the appropriate concerns around bias in AI models, but there are also opportunities for AI to help advance health equity. This large language model looked at clinical notes and was able to identify social needs from those clinical notes that are already existing, already in the EHR, and compared that to what some organizations are using to identify social needs with Z codes or ICD-10 codes that a clinician needs to code at the end of a visit. And this tool accurately identified social needs in 94% of patients solely from the existing clinical documentation. That graph on the bottom, the purple is Z codes, the orange is the predictions from the AI. You can see the AI outperforming Z code coding. Z codes are really only captured in about 2 to 3% of patient visits. So that's just a smattering of examples from research. And then on the next slide, there's also a ton of startups trying to solve some of these problems. And this is really only a partial list. These are all the startups using AI in healthcare. I'm sure there are dozens, if not hundreds more organizations and companies trying to solve some of these problems. And on the next slide, you heard a little bit about the hype of generative AI. And I wanted to spend also a minute speaking to that. This is the Gartner hype cycle. Right now, our expectations are through the roof, and most of these solutions have not been implemented at scale. And in order to get through some of these challenges and see a real benefit to both patients and care teams, we need to have tools that patients and care teams trust. And that's the only way we're going to get to this plateau of productivity or really get implemented at scale. HHS, Health and Human Services, has implemented or adopted this trustworthy AI framework that helps organizations think through the ethical implications of adopting AI tools in healthcare, and how we can really create and adopt tools that are trusted by users and patients and what's really required. Next slide is that framework. There are 6 elements. I'm going to walk through each of them. On the next slide is the fact that AI tools, in order to be trustworthy, need to be transparent and explainable. Next slide, please. So stakeholders should be able to understand how data is being used and how AI systems make decisions. The tools themselves need to be open to inspection. If you think about how new drugs are developed, for example, the clinical trials, drug features are transparent to the FDA, they're transparent to the public. Something similar probably needs to be adopted for AI solutions in healthcare. On the upper right, there's a study in Europe that looked at these are already approved AI products in the marketplace, and they evaluated on a scale of 0 to 100 for transparency. And 0 being not transparent at all, 100 being completely transparent. The median score was 29%. So really, most of these technologies are not fully transparent. The study on the bottom looked at transparency in the training cohort to help establish generalizability of an AI algorithm to identify skin cancer. Now, skin cancer can have different appearances depending on skin pigmentation. And so understanding generalizability is vital. But when they looked at these studies, only 20% of them included a description of the training population's race or ethnicity, and 10% described the skin tone. So it begs the question, are these models generalizable, and will they act the same for different populations? And this leads us to the next slide, which is a crucial aspect of AI. Does the AI work the same for all populations? This is another example that looked at training sets for machine learning tools that help to identify stroke. So often training data sets are sourced disproportionately from different geographic locations that are close to large academic medical centers, because that's where the research is taking place. And that's in the bottom figure. California, New York, Massachusetts, often where these studies were taking place. But on the top figure is the incidence of stroke in the United States. So it brings up the question, will this tool identify stroke as well for patients in Louisiana as it does for patients in New York? I don't know the answer to that, but we should have answers for these types of tools as they're deployed. Next slide, is the tool robust and reliable? So the top image is the number of studies in PubMed over time that are related to AI and machine learning. And each year over the last couple of years, there's been about 30,000 articles published trying to answer some of these questions. But some of the questions we need to consider is, what's the underlying data? Is it reliable? Is it representative? Were the methods to create the AI sound, and was it developed appropriately? Is the model performing as is expected, and does it change over time? What happens when you start your model on using ChatGPT 4, but now there's ChatGPT 5? Is the output the same? And what happens if that target population changes significantly from when you did your initial study to see the outcomes, and now you're not sure if the model is still applicable to that new population? And on the next slide, we of course need to have the same privacy standards that we've been implementing for years. Is there sensitive data that we need to treat differently? Does the individual understand how their data is being used? Are there specific legal requirements? And of course, what are the data sharing responsibilities? And then on the next slide, like all of our technology, we have to ensure that the AI tool is safe and secure. These are all articles from different cyber attacks over the last few months. And we need to make sure that the tools that we adopt don't increase the vulnerability and risk. And lastly, who's responsible and accountable for the AI performance and output? So this article on the top right is a lawsuit claiming that a payer was inappropriately denying claims using AI. This really necessitates establishing roles and responsibilities, having appropriate identity management, traceability, knowing that, how do you know that the AI and an AI arrived at a particular decision, and can a third party audit those responses? So like in Dr. Taylor's example, for Sepsis Watch, if Sepsis Watch does not identify sepsis in a patient, who's accountable for that outcome and the patient dies? Is it the physician? Is it the hospital? Is it the engineer who created the tool? Is it the company that sold the program? These are questions we need to have answers for. On the next page, I don't have answers to all these questions, but in order to come together to implement AI solutions that help improve our healthcare system, we absolutely need to be able to address them. And lots of organizations are thinking about how to govern AI use cases. And you can see this white ring in the middle of the black circle around the center that encapsulates regulatory compliance. So the FDA is very much thinking about how to regulate AI technology, but we're still waiting to see what that looks like. Around that circle, we also need organizations at the local level to have their own AI governance to ensure implementation of at their organizations are done so ethically and thoughtfully. We are lucky at CRISP that we have a pretty robust governance structure that we can leverage to help ensure that any use of AI is done responsibly and ethically. And then the next slide, I wanted to share a few different applications of AI use cases that are possible at CRISP. To be clear, these are not implemented at CRISP, but it could be possible and help solve real problems. I've organized them from low complexity and lower risk to higher complexity and higher risk based on that framework below, or that I've shared previously. And under each category, there's various different use cases. I'll speak to one of those use cases under each category just to give you a general sense of what could be possible. But in internal operational efficiency, it takes a lot of time for our project managers, outreach team, business analysts to document routine tasks. We could supplement a large language model with our internal policies to allow for our technical and project and outreach teams to spend less time doing that easy stuff and more time on the work that really needs their expertise. We could also have better insight into the utilization of CRISP tools. We've made a lot of progress on gaining insight into what's most valuable to CRISP users. But an AI model could help supplement that information with allowing an outreach team to more easily identify key users and user groups that could use more education or could identify a new use case that is more applicable to a different group. And under workflows and user experience, so today CRISP user interface is a one-size-fits-all model. This means that often users have to spend extra time hunting for the right piece of information that they need for each patient. We could more easily create displays of patient data so that a cardiologist, say, can easily find the data that's most important to them. They see the EKG, they see the labs and weights for patients with heart failure, or an NCO case manager sees something different where they are following a patient with diabetes and they can more quickly see the discharge summary from their last admission because of poorly controlled diabetes, and they can see the latest eye exam. These are opportunities for different use cases around AI. Also for data quality, our data comes from hundreds of different organizations. And some of those organizations apply data standards, but some don't, and that makes it difficult to do things as simple as graphing the amount of hemoglobin over time for patients with anemia that see different practitioners. We also have difficulty identifying gaps in HEDIS measures because some organizations don't code a colonoscopy as a colonoscopy, for example. And lastly, we have clinical decision support, and this is on the right side of the screen for a reason. This is the most complex. It has the most clinician-facing implications and higher risk for patients. But we do know clinicians and members of the care team like yourselves pore over CRISP data, and it can find it difficult to find the right data that you need. But wouldn't it be great if you could type into a prompt to ask CRISP, tell me the most important thing I need to know about this patient since I saw them 6 months ago. And that could really reduce the burden of hunting for the most salient data. But at CRISP, we want to take a thoughtful and iterative approach to AI use cases. And so we're working on the left side of the screen to think about what the most lowest risk use cases are so that we can continue to maintain the trust of our participants like yourselves and patients. We want to be sure that we're implementing these use cases thoughtfully and ethically. And so we're taking this crawl, walk, run approach and getting more comfortable with these use cases and having organizations like yourselves get comfortable with AI use cases to make sure that we're appropriately managing the risks that are inherent. And so I'll just end on the next slide. I know that many of you are attending this summit, not just because you're witnesses to the future of medicine, but are actually committed to shaping that future. And we're certainly at a unique time with this explosion of generative AI and the potential it has to solve really huge problems. But it may seem daunting given the risks. And we've been on this journey before for the last 15 years. We've wrestled with these complex challenges. We've implemented innovative solutions in the past. And we did so responsibly in a way that maintained trust throughout the state. And so it's up to us in this virtual room really to steer the course towards this future that we want AI to make healthcare better for all of us and for our patients, and to do so in a trustworthy way. And so we really have that responsibility together, and I hope we can go on this journey together. And thanks so much, and look forward to the questions and comments.
Thank you, Dr. Rabner and Dr. Taylor. This was a great presentation. We have about 10 minutes to go through some questions. I'll just use this time to remind folks, you can utilize the Q&A feature to ask and type in your question. And you can also upvote other folks' questions if you want to see that one specifically answered. We'll try to get through as many as we can. I did see some questions about the slides and the recordings. We did record this session, and we will record all sessions in the CRISP Summit. We'll provide those recordings on our website and YouTube channel, so you can review them at a later date. We'll also publish the slide decks and reference materials that we mentioned during these presentations on those channels as well. So with that, I will start reading off some of these questions. I think this one probably is best suited for Dr. Taylor. Someone writes, I'm very concerned about bias in using AI to make decisions about people. Is the AI community globally aware of this, and are they doing anything about it to eliminate biases when developing applications moving forward?
Yeah, thanks. I think the answer is that the field has a very bad history of this, but they're on the right trajectory. So the fact that this is as big of a problem as it is was sort of discovered as tracks were being laid on actual things. So there's all sorts of horrifying examples of big companies who have published a product that is flawed in a really significant manner because of data bias problems. Now, as a result of that, they learned that it is worth it to put the time and effort into making sure that those systems are as unbiased as possible. And so I would say that we can find lots and lots and lots of examples in the past in which there have been significant problems from this. I'm sure we will find more because companies vary in terms of their commitment to solving this problem. But I think in general, the field is very, very aware of this and knows that this is a fatal flaw, and nobody will use these tools if they introduce significant bias into decision-making. So it's a huge area of investment for a lot of big companies in how to eliminate bias in their data sets. And so I'm optimistic going forward, even as we can sort of shake our finger in recrimination at the field in the past. So.
Thank you, Dr. Taylor. This one has been upvoted a bunch. Are there any concerns about AI and HIPAA?
Yeah, I mean, I think we need to, this kind of goes into the privacy bucket. Is the technology legally compliant and doing what it needs to do to be able to protect individuals' privacy? And so AI certainly has its own risks, and maybe Dr. Taylor can speak to how kind of prompts that are input into, say, a ChatGPT are then used to train the system as a whole. We have to be very careful about putting any PHI into AIs that are not appropriately walled off.
Yeah, I mean, I would sort of expand on that by saying, are there any concerns? Which answer you get is going to depend on which end of the field you talk to. So certainly on the patient-facing side, absolutely, there are very legitimate, serious concerns about making sure that data is not inappropriately used in order to train these systems such that people's private information is encoded into these models. That's a thing that can happen, and so people are very careful about that. The other side of it is that if you talk to somebody who's purely on the technological side and is interested in building AI tools in order to work on healthcare, They have concerns about AI and HIPAA as well, and then it's difficult to put together a large enough data set in order to build the kind of models that they want to build. So from either direction, the answer is yes, but it's very much true that everybody's aware they have to abide by those rules for better or for worse, which I think is for better, to be clear.
Awesome. We have another question. How do you see AI impacting healthcare policies at a state, or I guess we can even expand this to a national level?
Yeah, I mean, I think we're starting to see how the federal government is responding to generative AI. HHS has this framework out. FDA is part of this process. I think we're going to see more organizations at the federal level setting policies that help regulate AI in the healthcare space to make sure that the products that come out and the technology that comes out is in line with these 6 different elements of a trustworthy AI. And I would guess that it's going to go beyond that as well. There's a new public-private partnership, CHAI, that you should check out. I think it's like chaihealthcare.org. They are helping to think through how to do this at scale and how to make sure that all the technologies that are come to the market are fit these criteria and are transparent and are trustworthy.
Someone asked a question about some of the use cases, Mark, that you provided. And they said for the high-risk use cases, I assume the PHI conundrum will first need to be resolved across the industry. Will there perhaps be a dependency on finalizing a unique patient identifier in healthcare?
I'll take the first part of that. If I'm understanding the PHI conundrum, I mean, we need to be able to use PHI for these technologies, which, to be honest, like lots of organizations are doing already. They found ways to wall off the tool so that it can ingest PHI without leakage of that information outside of that system. And said perhaps there's a dependency on finalizing the unique patient identifier in healthcare. I think that will certainly help with making sure different records from different places are matched correctly. We have our master patient index that helps to do that. There's actually AI use cases that could help us improve our master patient index by identifying when there are mismatches or when there are single records that should be matched together. But I hope that answers your question.
Awesome. I did get a question about if we're going to email the recordings and slides to folks, and the answer to that is yes. So all attendees will receive 2 emails. First email will include the survey for the event. So if you don't mind taking a few minutes out of your afternoon, it'd be awesome to get your feedback on the sessions and the event today. And then probably sometime tomorrow morning, you'll receive another email with the slides and the recording, and that's when those will be published to our website. If we didn't get to your question, I will follow up, and we will follow up by email. But thank you so much for attending this session. I want to thank Dr. Rabner and Dr. Taylor for their time. And great presentation. So we'll be back with our next session on the Maryland model and the AHEAD model at 10:15. So we'll see all of you back then.